going to turn it up and I'm going to be quiet.
Good morning, everyone. Are these slides showing up? Awesome. All right. Well, thanks, Mike. So my name is Amanda Gogol-Tagliaferro. I am a pediatrician at Akron Children's Hospital with our Locus Pediatric Care Group. I'm also a clinical associate professor of pediatrics at Northeast at Neomed. So I'm so happy to kind of join today and talk about just counseling on access to lethal means and my perspective of what that means for my interactions with my patients and families in the office, as well as just my own evolution, as a pediatrician and addressing this important but sometimes complex discussion with my families. So my objectives today are to provide an overview of counseling on access to lethal means, education, to discuss an acute mental health crisis or suicidal crisis through the lens of the adolescent patient, or for those of you who are not in the medical realm, the client. And then also to communicate the need to include counseling on access to lethal means to youth at risk, but also specifically in my patient population as a part of anticipatory guidance when we see kids in the office for their annual well visits. What is CALM? I'm sure everyone here in this room is familiar, but it's counseling on access to lethal means, and it's really was designed to be a collaborative effort between gun owners, mental health clinicians, and suicide prevention specialists. So its focus is how to connect with gun-owning families to have conversations about safeguarding firearms in ways that are both comfortable but also practical. For me in the office, the conversation really used to be, there's no firearms in the home, correct? Okay, let's move on. And really that framework has shifted both in the pediatric realm, but nationwide, in how we talk about these things. So for my career as a pediatrician, but for all of us that work in community settings with youth and families, we can have an honest conversation in identifying and supporting youth at risk for suicide. So the CALM program, based out of grew out of a program from the New Hampshire Firearm Safety Coalition. This coalition was founded in 1994, and its focus is bringing firearms retailers, instructors, and others who value access to firearms together in a way to talk honestly about injury and suicide prevention, to find practical strategies to reduce injuries from firearms. So the overarching goal of CALM training is to help families reduce access to items at home that could, cause serious harm or could also cause mortality if misused. So just wanted to touch on trends in suicide prevention efforts. So historically, most of the focus in suicide prevention is on the why, why a person, has a suicide attempt. Historically, we've helped people manage suicidal thoughts and try to reduce the mental distress that leads to a suicidal attempt. But overlooked is also the method. So the how, how a person, attempts suicide, the method that they use, because this can often determine if a person lives or dies. So the goal of CALM counseling is to reduce youth suicide by empowering providers to address the how through lethal means counseling and improved education with gun-owning families. So I wanted to touch on, an acute mental health crisis in the period from going from passive to active. So the period from where a person has some passive thoughts or is considering suicide to actually being ready to make an attempt. So the features are that it often comes on very rapidly and can really be difficult to predict. And it's often very brief, within minutes of going to in an acute mental health crisis to coming out of that acute crisis. And just the external factors or the triggers, things that we I'm sure all are familiar with, have heard of from our clients, but stressors like arguments, breakups, getting into trouble at school or trouble with the law can trigger this escalation, especially in our younger patients, to crisis mode. So speaking more specifically on that with adolescents, and thinking about the the timing and the development of the adolescent brain, nearly half of individuals seen in the hospital for care after a suicide attempt report, the data has shown that they report that they had thought about suicide within 10 minutes prior to the attempt. And you think about the impulsivity of the adolescent brain. I like to remind my patients that we know the prefrontal cortex, or the higher level decision-making center of the brain, doesn't stop developing until age 26. Teens are impulsive, but that's also part of biology. So we need to kind of bring recognition and awareness to that and work with our families in realizing that. I like to bring this up in the office to my patients, to kind of educate, but also to kind of get the parent and the teen reaction. And then this is the point in the office visit where things start to feel a little bit more heavy in conversation. And then I bring up a bad joke about how I got married when I was under 26. And I kind of wait for a few minutes, and then I say, well, I'm still married, so I guess maybe that was a good decision. And you're capable of doing that in the adolescent time period as well. And usually that brings a couple chuckles and helps to lighten the mood in the office. But it's also important to note that most people who consider suicide want to end their pain, but not die. And recognizing these facts with families, with clients in the office, it helps to open up a discussion on counseling on access to lethal means. So this is a figure just to say that method really matters. This is from the CDC, a 2019 figure. So for ages 0 to 24, you can see that the percentage of suicide deaths by methods, by and large, firearms is the largest. That yellow one, if you can't see, is hanging deaths, and then the much smaller is drug overdose, and then different other types of lethal means. So the lethality of the method is one of the largest factors in determining whether a person lives or dies. And we know that if the method a person wants to use is not readily available when they are ready to go through with an attempt, one of two things is likely to occur: delay or substitution to a less lethal method. As you see, the greatest number of youth deaths, suicide deaths in the U.S. is from firearms. They're the most lethal suicide method, but as you see here, they're also the most common method of suicide for youth under the age of 24. And just some statistics. So in 2020, firearm-related injuries became the leading cause of death for kids in the U.S. About 1/3 of kids in the U.S. live in a home with a firearm. And of these with the firearm, slightly less than half are unlocked. And then talking about suicide compared with less other lethal means, suicide attempts are fatal about 90% of the time compared to an overdose in statistical reviews. And then this one is really jarring for me, that over 80% of child firearm suicides involve a gun from a family member. So, I'm in the business of protecting children and keeping children safe. So, my own personal evolution has been that this has led me to really, bring up these discussions in my office with youth who, are having mental health concerns, but also as a part of, anticipatory guidance at well checks. So a note on reattempt is that for youth who do attempt suicide and then go on to live, lethal reattempts are less likely successful, which means that short-term interventions can save lives. There was a review of 170 studies that followed suicide attempts over time. On average, by the end of 10 years of the initial, study population, 4% of people ended up eventually, unfortunately, dying by suicide. And non-fatal reattempts were more common. About 20% of the initial study population of individuals had made a non-fatal reattempt over about 5 years. So the gist, as I mentioned, is that short-term interventions can save lives. The goal is to help clients or patients survive the period of acute crises so they can receive the care and support that they need. Most notably, 95% of youth who have a suicide attempt and survive will not go on to take their lives later. So the strategies that I use in the office for discussion is, really trying to be patient and family-centered, having open-ended conversation. And like I said, bringing it up at every visit now, especially with my younger families. So then when, children get to be that adolescent age, or if we're dealing with a situation where there are some mental health concerns, that it's not something that I'm bringing up for the first time. The strategies that in talking about firearms is recognizing that it's a conversation that brings a lot of emotions on each side. So no more am I saying, do you have any firearms in the home? Because I have learned that's a pretty judgmental, if family is viewing that, the doctor really wants me to say no to this, they may lie and, tell me no. So now I've kind of centered my approach on saying, if there are firearms in the home, let's discuss how they're stored, trying to be more open-ended with my approach. And then also trying to meet the family halfway. I have a lot of moms who have firearms in their home, but they're, for purposes of self-defense, they frankly don't feel safe at home. And they feel, in their mind that they do need firearms to keep their family safe. So I do say, let's try to balance the preference with the need to keep your son or daughter who, or your young children, from getting a hold of a, firearm at this time. So specific, thoughts or questions about, firearm safety that I like to bring up in my visits is talking about access. Where are firearms? Are they in the home? Are they somewhere else that your child may go? I am that mom in my kids' circle of friends that if there is going to be a play date, I really try to model that behavior that I teach of, just asking, if kids are going to be at someone's house, to just kind of, and it's the same thing of as knowing, who's in the home, and, the same questions that I'm sure we all ask, just kind of bringing, the thoughts about, firearms, the same way you would ask about bike helmets or, car seats or seat belts, really trying to bring that question to the forefront. Storage options. If kids are struggling or they're having some mental health concerns, I always tend to try to ask, is there an alternative place that your firearm can be stored if it's already locked, and ammunition is stored separately. And then just trying to figure out the reason for why firearms exist in the home. Some people have them for recreation, for self-defense, and really trying to gauge at that for, in a non-judgmental way. And then talking about other forms of lethal means, medications is one that we really try to address as well in the primary care clinic. So having conversations with my families about keeping, only medications that the family uses and needs, but in quantities that are much less likely to cause harm. We're seeing a lot of grandparents who are raising children. I'm sure you're seeing all that as well. And they may be on, some, diabetes medications or heart, cardiovascular medications that really could cause, a great level of potential harm if they have inappropriate use or misuse. So really trying to talk about that, as well as proper disposal. So just being able to kind of have those conversations. I also suggest, going through medications and getting rid of any that are no longer used. keeping those in a small quantity that you have on hand, or, having a medication lockbox. We have at my clinic, and actually across the Akron Children's Network, we've received some grants from the Ohio AAP and some other grants that we all have medication lockboxes that we can hand out to our families as well. So that also helps kind of open up the discussion in a non-judgmental way. And just the final piece, that I go through with my families and my patients is having a safety plan. All of our, in conjunction with our behavioral health team, we have a behavioral health safety plan that really kind of helps go through, using healthy mechanisms, coping mechanisms, having, triggers of awareness of when a patient may be going into, more of an acute mental health crisis mode, and kind of going through that, and, having a safety plan for not only, firearm storage or lethal means storage, but just, if someone starts to feel and go into that mode. I've found that going through that safety plan together really helps. And then I think the part of this also is following up. It's not just an office visit where we talk about it, but also following up, maybe a couple weeks down the road, or, at the follow visit in a month, like, hey, last time we talked about, storing, firearms separately. Tell me where you are at in that journey in your home. And really just trying to, like I said before, destigmatize the language of firearm safety, and just bringing it up at, every visit as part of anticipatory guidance. So I thank you all for your time as far as this goes today. Any comments, or I would appreciate that.
This is so timely, right? I talking about suicide prevention consideration addressing is never not timely, to use a double negative.